Welcome back to e-textbook of Congenital Heart Diseases. In this module, we are going to see hypoplastic left heart syndrome. Hypoplastic left heart syndrome represents a very diverse group of pathology. The basic anatomic substrate will be atresia or hypoplasia of the left atrioventricular valve or the mitral valve, hypoplasia of the left ventricle. This is the situation when there is no intraventricular communication or a very diminutive VSD. If there is a large ventricular septal defect, LV will be adequately developed. Another component is the atresia or hypoplasia of aortic valve and ascending aorta. The physiological and clinical definition of hypoplastic left heart syndrome can be given as follows. The systemic circulation in this scenario is dependent on the right ventricle in association with atresia or severe hypoplasia of the aortic valve. There are various theories that has been given for the etiology of this disease. Certain genetic abnormality in the transcription factors have been determined. A displacement of the septum primum, which causes a reduced flow of blood through the foramen ovale from the right atrium into the left atrium in the fetal life, contributes to LA hypoplasia and reduced flows into the LV. This is one of the hemodynamic theories proposed. Another etiological hypothesis is that if there is an obstructed left ventricular outflow tract, this results in high left ventricular end diastolic pressures and left ventricular endocardial fibroelastosis, and that perpetuates the hypoplasia. When we look at the morphological specimens of hypoplastic left heart syndrome, we find that the left atrium is often hypoplastic. The left atrial appendage may sometimes be dilated with markedly hypertrophied walls. In about 1/3 of the patients, the interatrial septum may be intact or having a very small foramen ovale. The primum septum is often deviated to the left. The left ventricle is small, hypertrophied, and shows marked endocardial fibroelastosis. The mitral valve and the aortic valve may either be hypoplastic or atretic. Ascending aorta is very hypoplastic and in most of the situation just serves as the conduit for coronary. Coarctation is seen in almost 80% of the patients. Often there will be a preductal shelf, but sometimes there may be a paraductal shelf. Ventriculocoronary fistula may be seen less commonly, contrary to pulmonary atresia with intact ventricular septum, where the right ventricle dependent coronary circulation is more commonly seen. In the hypoplastic left heart syndrome, the ventriculocoronary fistula is not so common. When we look at the hemodynamics, there is a complete admixture at the right atrium. The pulmonary venous return that comes from the pulmonary veins into the left atrium enters the right atrium through the foramen ovale, and there is a total admixture. The right ventricular output is actually representative of the combined QP and QS. The QP to QS ratio is dependent on the relative ratio between the pulmonary vascular resistance and systemic vascular resistance. Whenever there is tricuspid regurgitation, it adds to the ventricular volume overload. When we evaluate a patient of hypoplastic left heart syndrome with echocardiography, we analyze the systemic veins, the interatrial septum, the left atrium, mitral valve, the left ventricle, the aortic valve, aortic root and coronary origin, the ascending aorta, arch, coarctation and the ductus arteriosus, the right ventricular function, the tricuspid regurgitation and the pulmonary tract. Let us start the segmental approach from systemic veins. The IVC and hepatic veins often show congestion. They are dilated due to heart failure, which is almost always present. The IVC congestion and dilatation will be augmented since most of these babies may be on positive pressure ventilation. In this subxiphoid short axis view, we are able to appreciate the dilated, congested inferior vena cava and the dilated hepatic vein. We notice that there is no inspiratory collapse of significance in the inferior vena cava. This is a sign of elevated right atrial pressure. When we move on to the interatrial septum, leftward deviation of the primum septum is often seen, and this results in reduction in the size of the left atrium. Most often, the patent foramen ovale is very small and is restrictive. Sometimes the PFO may be generously open. Interatrial septum is often thickened, sometimes very muscular, and there may not be an interatrial communication at all in some patients. In the subxiphoid short axis view, we notice that the primum septum is deviated to the left posteriorly towards the posterior left atrium. The foramen ovale is anatomically very small. However, there is not much of turbulence. We can see a laminar flow from the left atrium into the right atrium shown as the red color. In this patient, the anatomic size of the foramen ovale is less than 4 mm. However, there is not much of turbulence that is noted. Apical four-chamber view once again illustrates the leftward deviation of the primum septum. The deviation of the primum septum results in reduction in the size of the left atrial cavity. Some infants may have very thick interatrial septum. In this example that is shown, we are not able to see the thinner portion of the fossa ovalis at all. Interatrial septum may remain very thick. You can also see that the right ventricle is grossly dilated, very trabeculated. Adequacy of the interatrial septal communication will have a clinical impact on the presentation of the patient. In the presence of minimally restrictive patent foramen ovale, the left atrial and the pulmonary venous pressures are increased. This pulmonary venous hypertension results in persistence of the fetal pulmonary vasospasm. The high fetal pulmonary vascular resistance persists into the postnatal period. This prevents flooding of the pulmonary circulation. The systemic cardiac output is so maintained as long as the duct is open. Let us imagine another clinical scenario where the interatrial septal communication or the foramen ovale is very patulous and there is a large unrestricted atrial communication. Here, the pulmonary venous pressures very quickly drop. The pulmonary venous pressures becomes equal to the right atrial pressures. There is no pulmonary venous hypertension. In these patients, the pulmonary vascular resistance drops to very low levels. This results in clinical presentation of a shock-like state due to marked fall of the pulmonary vascular resistance. On the other extreme, if the patent foramen ovale is extremely restrictive, or in the worst case scenario there is intact atrial septum, there is very severe pulmonary venous hypertension. This pulmonary venous hypertension results in marked pulmonary arteriolar vasospasm and elevates the pulmonary vascular resistance to very high levels. If the duct is wide open, the systemic cardiac output is well maintained, but these patients will have very low systemic saturation due to low pulmonary blood flows. The reduction in the pulmonary blood flow is caused by high persistent fetal pulmonary vascular resistance, similar to the situation of persistent pulmonary hypertension of newborn. We will show now 3 different examples of these atrial septal communications. The scenario 1 will be a mildly restrictive foramen veil. Scenario 2 will be a totally open foramen veil. Scenario 3 will be an extremely restrictive foramen veil. This is a minimally restrictive foramen veil. The anatomic size of the foramen veil is around 2.8 millimeters. You can see a mild turbulence on the color Doppler. When we look at the interatrial gradients by a spectral Doppler, we identify that the mean interatrial gradient is around 3 millimeters of mercury and the peak interatrial gradient is around 6 millimeters of mercury. This offers a minimal resistance to the flow of blood from the left atrium to the right atrium, and the pulmonary venous pressures are around 3 to 6 millimeters of mercury higher than the right atrial pressures. In the second scenario, the foramen veil is totally patulous. In other words, there is a large atrial septal defect. And when there is a large atrial septal defect, there is no left atrial hypertension at all. There is no pulmonary venous hypertension. The pulmonary venous pressure becomes equal to the right atrial pressure. The last clinical scenario will be a very muscular interatrial septum with an extremely restrictive foramen veil, and that causes significantly high interatrial gradients. In this subset of patients, due to marked pulmonary venous hypertension, the pulmonary vascular resistance is very high. There is a pulmonary arteriolar intense vasospasm. These patients have very low pulmonary blood flow, marked hypoxia. The foramen veil is extremely restrictive and the left atrium is very hypertensive. One of the hallmark of this restrictive foramen veil is an extremely muscular interatrial septum. These interatrial septums are very thick. They don't yield well to a balloon septostomy. In one of the extreme examples of inadequate interatrial mixing, the atrial septum may totally be muscular. There won't be a foramen veil at all, and in these patients the left atrium will decompress itself through small unroofings in the coronary sinus. The left atrial blood enters the coronary sinus through small areas of unroofing in the coronary sinus and get an exit into the right atrium. This will be the only egress for the pulmonary venous blood into the heart. In one such patient, where the interatrial septum is intact and the left atrium is decompressing through a small unroofing in the coronary sinus, this parasternal long axis view is showing the entry point of the coronary sinus into the right atrium. You can see the dilated trabeculated right ventricle, and the tricuspid valve shows only minimal incompetence. When we do a spectral Doppler tracing of this interatrial flow, we can observe that the interatrial gradient is very high. The mean gradient is 10 millimeters of mercury. And whenever the left atrium contracts during atrial systole, the blood flow reaches a peak velocity of almost around 40 millimeters of mercury. It exceeds 3 meters per second. In these patients, we can imagine how severe will be the pulmonary venous hypertension. The interatrial septum will need a variety of interventions to relieve the pulmonary venous hypertension. Sometimes it may be in the form of balloon septostomy or atrial septal stenting, most cases will need a surgical atrial septectomy. This is an interatrial septum that has been opened out with a balloon atrial septostomy. We can see the flap of the septum primum floating in the right atrium. Only a very few patients with hypoplastic left heart syndrome can be palliated with a balloon atrial septostomy, since most of this fossa vallis will be very thick and muscular. After a balloon atrial septostomy, a color flow Doppler indicates that there is a laminar flow of blood from the left atrium into the right atrium, and there is no interatrial gradient. When the interatrial septum is very thick and muscular, a balloon septostomy is not going to offer any significant advantage. Atrial septal stenting may have to be resorted for creating a dependable interatrial communication. This is a patient who had an atrial septal stenting for a hypoplastic left heart syndrome. In this apical view, we see the atrial septal stent in position. The stent needs to be at least 9 to 10 millimeter in diameter to allow an adequate cardiac output. We can also see that the right ventricle is grossly trabeculated, the right ventricle is thick, there is a mild to moderate right ventricular systolic dysfunction, there is a lot of endocardial fibroelastosis and dystrophic calcification of the right ventricular trabeculae. A color Doppler across the interatrial septum shows that there is a laminar flow from the left atrium into the right atrium through the interatrial septal stent. In the apical four-chamber view, we are able to appreciate the large size of the atrial septal stent. The right ventricle is dilated, trabeculated, and the endocardium is significantly echogenic. In the segmental approach, we now move on to the atrioventricular valves. We will see the mitral valve and then the tricuspid valve. The mitral valve may show gross hypoplasia with very minimal antegrade flows or sometimes totally atretic. If the left ventricle is severely hypoplastic, the amount of blood flow from the left atrium to left ventricle will be very low and so may not show any gradient across a hypoplastic mitral valve. So high transmitral gradients are very unusual in the setting of hypoplastic left heart syndrome. The mitral valve is very hypoplastic. The mitral valve annulus is much smaller than the tricuspid valve. You can also notice that the left ventricle is very hypoplastic. The left ventricular endocardium shows areas of fibroelastosis and calcification. The left ventricular apex does not extend up to the right ventricular apex. Even though the mitral valve is hypoplastic, we can see the opening and closure of the mitral valve. The left ventricle is very significantly hypoplastic. The papillary muscles are showing fibrosis. The left ventricular papillary muscles are markedly echogenic. There is very minimal blood flow from the left atrium into the left ventricle, and so there is no appreciable transmitral gradient. When the mitral valve opens, there is often an antegrade blood flow from the LV into the aorta. If the left ventricle is well formed, then in the previous example, the left ventricular apex extends a little bit lower. Here you can see that the left ventricular cavity is marginally better formed than the previous examples. Some patients may have complete atresia of the mitral valve. There will not be any opening in the membrane between the left atrium and the left ventricle. Such an atretic mitral valve will be associated with marked hypoplasia of the left ventricle. Here, literally the left ventricular cavity is not seen at all. Tricuspid valve is morphologically normal. However, its function is highly dependent on the right ventricular systolic function. When the right ventricular contractility is very good and the right ventricle is not dilated, the tricuspid valve leaflets co-opt very well, and there is usually a good cooptation of the tricuspid valve, good competence of the tricuspid valve. In this example, there is no tricuspid valve regurgitation at all. You notice that the right ventricular systolic contractility is normal and the tricuspid valve cooptation is also normal. Some patients with hypoplastic left heart syndrome in neonatal period may have reduced right ventricular contractility, but in early neonatal period, the tricuspid valve will be competent. However, as age advances, with the continuing poor right ventricular systolic function, tricuspid valve regurgitation becomes more severe. As the baby gets older, the right ventricular contractility becomes less and the tricuspid valve leak starts. Many patients will have a mild to moderate tricuspid regurgitation. When there is a severe tricuspid regurgitation, the prognosis of these patients are very poor. The mechanism of tricuspid regurgitation is very similar to mitral regurgitation that happens in dilated cardiomyopathy with severe left ventricular systolic dysfunction. In the initial stages, it is due to tricuspid valve annular dilatation, but later, as the right ventricle becomes dilated more and more, the leaflets get tethered and there is a restricted mobility, similar to Carpentier type 3B dysmobility of the mitral valve leaflets. In the presence of severe tricuspid regurgitation, we may notice that the right ventricular contractility may appear falsely better. But we should understand that this is due to the severe tricuspid regurgitation. Severe tricuspid valve regurgitation will need tricuspid valve repair. This is often done with a suture annuloplasty or ring annuloplasty of the tricuspid valve to reduce the annulus, and this will partially correct the mechanism of tricuspid regurgitation. After a tricuspid valve ring annuloplasty, the tricuspid valve tethering will still persist. However, the quantum of tricuspid regurgitation will become marginally better. Let us move on to analyzing the ventricles in hypoplastic left heart syndrome. We'll start with the left ventricle and then move on to the right ventricle. Left ventricular hypoplasia is the key to diagnosis. The left ventricle may show varying degrees of hypoplasia. In the presence of large ventricular septal defect, however, there may not be a substantial LV hypoplasia. The LV hypoplasia is often associated with left ventricular endocardial fibroelastosis. The left ventricular hypoplasia is appreciated by the small size of the left ventricle. The apex of the left ventricle will not extend downwards up to the apex of the right ventricle. The left ventricular fibroelastosis is shown by the echogenicity seen on the interventricular septum and on the papillary muscles. LV apex is far above the level of the right ventricular apex. Ventricular-coronary communications may be seen in a very small proportion of children with hypoplastic left heart syndrome. These are examples of echocardiogram of patients with left ventricle to coronary communications. You can see that there is color flows through the left ventricular myocardium from the LV cavity towards the epicardial coronaries. And whenever these ventricular-coronary communications are abundant, they are associated with very poor prognosis. There are certain index that has been described for assessing the left ventricular hypoplasia. One such index from the Boston Children's Hospital is called as the Rhodes score. This Rhodes score takes into account the body surface area, the aortic root dimension indexed for body surface area, the long axis ratio, which refers to long axis of the left ventricle compared to the long axis of the heart, the mitral valve area indexed for body surface area. It has not been found to be too useful in clinical practice. It was initially suggested to decide on biventricular versus univentricular palliation in patients with neonatal aortic stenosis. In the presence of a large ventricular septal defect, the LV hypoplasia will not be very marked. In this patient with a hypoplastic mitral valve and hypoplastic left ventricle, there is a large ventricular septal defect. A good right ventricular systolic contractility indicates a very good prognosis in patients with hypoplastic left heart syndrome. This is an example of a patient with hypoplastic left heart syndrome with preserved right ventricular systolic contractility. When the right ventricular contractility is very good, long-term survival is possible. This is a patient surviving to 7 years of age after extracardiac conduit Fontan surgery, after having completed all the 3 stages of Norwood. We can see that the right ventricular systolic contractility is good and the tricuspid valve coaptation is also very good. Whenever the right ventricle is markedly dilated, highly trabeculated, non-compacted, and showing poor right ventricular contractility, the prognosis is not very good. In extreme patients, the right ventricular endocardial cavity may show dystrophic calcifications and right ventricular endocardial fibroelastosis. All patients with hypoplastic left heart syndrome may not have very severe degrees of LV hypoplasia. This is a patient with a borderline left ventricular hypoplasia. Because of mild hypoplasia of the left ventricle and the mitral valve, there is an accelerated blood flow from the left atrium into the right atrium through the foramen ovale. The mitral valve and the left ventricle are hypoplastic. The apex of the left ventricle does not extend as much down up to the apex of the right ventricle, and the mitral valve z-score is -3. Let us now move on to aortic and the pulmonary valves, the 2 semilunar valves. The aortic valve may entirely be atretic and the ascending aorta will be very narrow. In this parasternal long axis view, you can see a small parallel line that is seen in the middle of the picture. This represents the hypoplastic ascending aorta. Anterior to the hypoplastic ascending aorta is the large pulmonary valve. On a parasternal long axis view, when we measure the ascending aorta, it's only around 3 millimeters. The size of the ascending aorta is an important determinant to decide on the success of the Norwood stage 1 surgery. If the ascending aorta is extremely hypoplastic, measuring only 1 to 2 millimeters, it proves as a very high risk candidate. It is this ascending aorta that is going to be the conduit of blood from the systemic circulation towards the coronary route. And so, if this ascending aorta is extremely hypoplastic, it is associated with coronary hypoperfusion that will result in poor ventricular function and ultimately poor survival. The pulmonary annulus and the pulmonary valve are many-fold larger than the hypoplastic ascending aorta and the atretic aortic valve. In this, another example of hypoplastic left heart syndrome, there is a marked hypoplasia of the aortic annulus and ascending aorta. However, the aortic valve is not atretic and there is very minimal antegrade flow. We can see the brief systolic contractility of the hypoplastic left ventricle, even though there is substantial left ventricular endocardial fibroelastosis. We can notice the antegrade blood flow from the hypoplastic left ventricle into the ascending aorta. However, the left ventricle, the aortic annulus, the aortic root and the ascending aorta are severely hypoplastic. On a high parasternal view, we can appreciate the hypoplastic ascending aorta. The antegrade blood flow in the hypoplastic ascending aorta is shown as a red systolic flashing of color. We can see the ascending aorta continuing as the arch of the aorta and the large innominate artery being given off from the proximal arch. Pulmonary valve is very important because it sustains the systemic circulation. In this short axis view, we can see the trileaflet pulmonary valve, which is morphologically normal. It is important to check the competence of the pulmonary valve in the long axis view with color Doppler signals, because the pulmonary valve carries both the systemic and the pulmonary output. The short axis view shows the dilated main pulmonary artery, the dilated right and the left pulmonary arteries. We can see the very small diminutive ascending aorta and note the comparative large sizes of the branch pulmonary arteries. The color Doppler echo shows the flows across the pulmonary valve. There is a very trivial pulmonary valve regurgitation. With advancing age, the dilated pulmonary route will have increasing degrees of regurgitation. Ductus arteriosus or PDA is a very important structure that maintains the systemic circulation from the main pulmonary artery. Imaging the ductus and assessing the flows across the ductus has important decisions on the management strategy. The PDA is best visualized on high parasternal view with the probe in sagittal plane on the left first intercostal space. This view is also called as the ductal view. In this high parasternal long axis view, which is also called as the ductal view, we can notice that the main pulmonary artery continues through the ductus into the descending thoracic aorta. We can measure the size of the ductus in comparison to the size of the descending thoracic aorta. When the ductus is wide open, there is a free flow of the blood from the main pulmonary artery through the ductus into the descending thoracic aorta, thereby maintaining a good systemic cardiac output. You can notice that there is a total right to left shunt from the pulmonary artery into the aorta in systole. However, in mid and late diastole, we can see a flow reversal as shown by a red colored flow from the thoracic aorta back into the main pulmonary artery. This is due to the fact that the pulmonary vascular resistance will always be marginally less than the systemic vascular resistance, and so this will allow a flow back from the aorta into the pulmonary artery during diastole. When we do a spectral Doppler interrogation of the ductus, we can notice that there is a flow from the pulmonary artery into the aorta, sometimes with a peak velocity of as high as 3 to 3.5 meters per second. This may not be indicative of an obstruction, but this is due to large flows through a long tubular duct. Once the PDA starts constricting, we can notice the turbulence of blood flow from the pulmonary artery into the descending thoracic aorta. We can also see the anatomic size of the ductus becoming smaller, and this will be an indication for starting prostaglandin therapy. Spectral Doppler pattern of that patient was showing a PDA velocity in systole of close to 3 meters per second. But even when the Doppler velocities are close to 3 meters per second, which will equate to a 36 millimeters of mercury gradient, still the femoral pulses were well felt. As we discussed earlier, the high gradient is not just due to obstruction alone, it is due to the entire cardiac output going through the ductus arteriosus into the descending thoracic aorta. With advancing age, the ductus becomes more and more smaller. It becomes very restrictive. At this moment, the entire systemic cardiac output will be at a serious jeopardy. The patient will be in a state of shock, hypotension, due to marked ductal constriction. Once the ductus gets very severely constricted, the aortic pressures drop significantly and the systemic vascular resistance will be very low compared to the pulmonary vascular resistance. And so the flows from the pulmonary artery through the restrictive ductus into the descending thoracic aorta will be systolo-diastolic, will become continuous. Such a narrow ductus can be totally opened to a large lumen with initiation of prostaglandin E1 infusion. This is the echocardiogram after initiating prostaglandin E1 therapy. Echocardiographic visualization of the entire aortic arch, the isthmic area and the postductal region should be done with meticulous care. The aortic dimensions at various levels like the transverse arch, isthmus and postductal region all will have major impact on surgical correction. One of the alternative options currently adopted is hybrid stage 1 correction of hypoplastic left heart syndrome. In this modality of treatment, the ductus arteriosus is stented to provide unrestricted blood flow into the descending thoracic aorta. And to have a control over the pulmonary blood flow, bilateral pulmonary artery banding is done. This is a ductal view of a patient who has undergone hypoplastic left heart syndrome stage 1 hybrid palliation. We are able to see the stent, the blood flow through the stent and the tightly narrowed pulmonary arteries due to the bilateral PA peripheral banding. A comparison of the spectral Doppler pattern across the ductus arteriosus before and after initiating the prostaglandin E1 therapy can be identified very well. We can see that there is a systolic peak velocity from PA to aorta with a maximum velocity of around 2.6 meter per second before initiating prostaglandin. There is a diastolic reversal of blood flow from aorta back into the pulmonary artery because the pulmonary vascular resistance remains lower than the systemic vascular resistance. After initiating prostaglandin E1 therapy, the peak velocity reduces to 1.3 meter per second. Once again, in this spectral Doppler pattern, we can identify that there is a diastolic reversal of flow from the aorta back into the pulmonary artery, indicative of lower pulmonary vascular resistance and higher systemic vascular resistance. The ductal stent is shown in this short axis view. The size of the ductal stent has to be large enough to accommodate the entire systemic cardiac output. Ideally, the stents are around 8 to 9 millimeters in diameter. This is another patient who was palliated by the same method, hybrid stage 1 procedure for hypoplastic left heart syndrome. You can identify a large ductal stent in place. Due to large size of the ductal stent, the flow in the ductal stent into the descending thoracic aorta will be laminar. You can also notice the high velocity turbulent flow in the banded pulmonary artery. The right pulmonary artery anatomically is looking very small because of the tight RPA band. Before a hybrid stage 1 palliation of hypoplastic left heart syndrome is planned, the following parameters needs to be assessed on echocardiogram. The transverse arch and isthmus diameter. Is there any posterior aortic shelf? What is the ductal diameter and what is the ductal length? And the descending thoracic aortic diameter. The ductal diameter is important because the size of the ductal stent should be much more larger than the ductal diameter. This is to prevent the stent embolization. The ductal length needs to be measured because the entire length of the ductus has to be stented, and any unstented portion of the PDA will go in for a severe stenosis. The descending thoracic aortic diameter is also very significant because the ductus stent should have a diameter which is at least matching the descending thoracic aortic diameter. If there is a posterior aortic shelf, that is a substrate for coarctation, and these patients will have what is called as a retrograde coarctation. That means a gradient from descending thoracic aorta to arch of the aorta. The pressures in the arch of the aorta will be less than the pressures in the descending thoracic aorta. The transverse aortic arch and isthmus diameter is very significant because this is going to determine, after a stage 1 hybrid procedure done on hypoplastic left heart, whether the carotid and the coronary perfusion are going to be adequate or not. Ideally, there should not be any posterior aortic shelf at all. In this example, there is no posterior aortic shelf. If there is a posterior aortic shelf, the ductal stent will resume normal flows from the main pulmonary artery into the descending thoracic aorta. However, there will be a retrograde coarctation resulting in inadequate cerebral and coronary blood supply. We should look at the ductus diameter. In this example, since the patient is on prostaglandin E1, the ductus has got a diameter of around 7 millimeters. If you are going to deploy a 7 millimeter stent or an 8 millimeter stent in such a wide open ductus, the stent has got a very high chance of embolization. So the prostaglandin has to be reduced in its dose, the ductus made a little bit more restrictive, and then the stenting has to be done. Measuring the entire length of the ductus on a ductal view is very crucial. The length of the ductal stent should be longer than the length of the ductus arteriosus. Any portion of the ductus which is left uncovered will have a very severe ductal area stenosis once the prostaglandin effect goes away. This will result in serious systemic hypoperfusion. Measuring the descending thoracic aortic diameter is also important, since the ductal stent has to at least match the descending thoracic aorta. It cannot be smaller than the descending thoracic aorta. To reiterate, before a ductal stenting, as a part of stage 1 rehabilitation of a hypoplastic left heart syndrome, we should take into account the transverse arch and isthmus diameter, exclude a posterior aortic shelf, see the ductal diameter and see the ductal length, and measure the descending thoracic aortic diameter. In all patients with hypoplastic left heart syndrome, the branch pulmonary arteries are uniformly large. In the management of hypoplastic left heart syndrome in a newborn, there are two basic therapeutic options. One will be a conventional Norwood stage 1 surgery. The second will be the hybrid stage 1 palliation. In a conventional Norwood surgery, the main pulmonary artery will be anastomosed to the undersurface of the aortic arch, thereby giving the right ventricular cardiac output through the pulmonary artery into the arch of aorta. To maintain the pulmonary blood flows, a shunt will be inserted from innominate artery into the right and left pulmonary arteries. Sometimes a sano shunt is done, which means a shunt will be inserted from the right ventricular anterior wall directly to the pulmonary arteries. In hybrid stage 1 palliation, surgically bilateral PA band is done, and this will be followed by a ductal stenting. This is a short axis view of the branch pulmonary arteries after a conventional stage 1 Norwood surgery. You can see the continuous flow through the BT shunt into the branch pulmonary arteries. Both the right and the left pulmonary arteries are seen, and the distal insertion of the shunt is also seen. In hybrid stage 1 palliation, both the pulmonary artery are tightly banded, very close to their origin. This is again a short axis view showing the mosaic color flow into both the right and the left pulmonary arteries. The turbulence is caused by a tight RPA and LPA ostial banding. Ideally, the banding has to be done to make the pulmonary artery get reduced to a diameter of between 3 to 3.5 millimeters. The purpose of banding is to restrict the pulmonary blood flows and reduce the pulmonary artery pressures so that the distal pulmonary vascular bed will be suited for a bidirectional Glenn shunt at a later date. So the pulmonary artery banding has to be very tight in order to give a distal pulmonary artery pressures of less than 20 millimeters of mercury. Following a hybrid stage 1 palliation, the continuous wave Doppler across the ostium of the right pulmonary artery is showing a band gradient with peak velocities of more than 4 meters per second, which will equate to a peak gradient of around 70 millimeters of mercury. Also notice that the end diastolic gradients are close to 2.7 meters per second, which indicates that the band is fairly tight and the distal pulmonary vasculature is well protected. Similarly, the left pulmonary artery band is also assessed with a continuous wave Doppler, and we find a peak gradient of close to 66 millimeters of mercury and a mean gradient of 38 millimeters of mercury, indicating the adequacy of the PA band. When we assess the arch of aorta in a hypoplastic left heart syndrome, we notice the severity of hypoplasia of the arch branching pattern, the presence or absence of a posterior aortic shelf, the size of the ascending aorta, and the pattern of flow in the arch. This is a suprasternal view showing the long axis of the aortic arch. In this patient with hypoplastic left heart syndrome, the ascending aorta, arch, and the descending aorta are not extremely hypoplastic. When we look at the color flows in the distal arch, we can find that there is a small antegrade flow in the distal arch. This is because this patient has got an opening aortic valve and there is some cardiac output that comes in the ascending aorta and maintains the systemic circulation up to the arch of the aorta. We can notice that in the descending thoracic aorta, there is a red flow, which is an indicator of the flow from the ductus arteriosus from the main pulmonary artery into the beginning of the descending thoracic aorta. If the antegrade flow through the aortic valve is very minimal, the flow in the arch of the aorta will entirely be from the descending thoracic aorta towards the ascending thoracic aorta. And so the color coding of the Doppler in the arch will be red. In this suprasternal long axis view, we can notice that the ascending aorta and arch are more hypoplastic than the previous example, and there is a complete reversal of the flow in the transverse arch. When there is complete aortic atresia, there is no antegrade flow at all, and so the whole arch will have a retrograde flow, not only in systole but also in diastole. Another observation that is made during the aortic arch assessment on echocardiogram is the presence or absence of a posterior aortic shelf. In a large majority of the patients, there will be a posterior aortic shelf. When there is a posterior aortic shelf, if we adopt the strategy of hybrid stage 1 palliation, the ductal stent will maintain a good forward flow from the main pulmonary artery through the ductal stent into the descending thoracic aorta. However, the circulation to the brain, the arms, and the coronaries will only be maintained if there is an adequate sized isthmus and absence of a posterior aortic shelf. In the presence of a significant posterior aortic shelf, there will be a retrograde coarctation and an underperfusion of the arms, brain, and the heart through the carotid and cerebral circulation. Coarctation due to a posterior aortic shelf sometimes may not manifest in the neonatal period and may present as coarctation later in child. In this example, a 7-year-old child who had a stage 3 completion of Norwood surgery at the age of 3.5 presented with severe arch narrowing and the coarctation was stented. The echocardiogram shows the stent in the proximal descending thoracic aorta. Need for aortic interventions in the region of arch can happen even after years of follow-up after Norwood surgery. The color Doppler flow in the aortic arch of this patient who had a stenting of the coarctation shows that the flows are quite laminar and there is no residual coarctation. We can see the small metal struts of the stent in the proximal descending thoracic aorta. In patients with hypoplastic left heart syndrome who have gone through Norwood stage 2 and stage 3 surgeries, even very minimal aortic gradients at the level of coarctation will not be tolerated and will precipitate earlier right ventricular systolic dysfunction. And so these patients may need an intervention for the coarctation at a much lower gradient than in another patient with coarctation. Coming to the analysis of coronary arteries in hypoplastic left heart syndrome, the coronary arteries arise from the native hypoplastic aortic root. In the presence of aortic atresia, the coronary flows are dependent on the size of the ascending aorta. So, in aortic atresia, if there is an extremely hypoplastic ascending aorta and the aorta is measuring less than 2 millimeters, it can lead to coronary ischemia, thereby perpetuating ventricular systolic dysfunction. If there is an antegrade flow through the aortic valve, the coronary flows will be marginally better. In this parasternal short axis view, a large pulmonary valve is shown anteriorly. Behind the pulmonary valve, there is a very small aortic root. On either sides of the aortic root, we can see a parallel track of left coronary artery and right coronary artery, which are shown with an arrow. When we reduce the color Doppler Nyquist limits to very low levels, in this instance, the Nyquist velocity has been reduced to 15 centimeters per second. We can appreciate the low velocity flows through the left coronary artery and right coronary artery. You can see the extremely diminutive size of the aortic root. The still frame of the parasternal short axis view shows the left and the right coronary artery arising from the hypoplastic aortic root. The second stage palliation of hypoplastic left heart syndrome will involve bidirectional Glenn shunt. If the patient had been palliated previously with a BT shunt or with a Sano shunt, the shunt will be removed and the right superior vena cava will be anastomosed to the right pulmonary artery to complete the bidirectional Glenn shunt. If the patient had been palliated previously by bilateral PA banding as a part of stage 1 hybrid procedure, the bands will be removed, a pulmonary artery new confluence will be formed between the right hilum to the left hilum of the PA and the Glenn shunt will be done. This is a suprasternal view of a patient who had a bidirectional Glenn shunt after Norwood stage 1 procedure. The stage 3 palliation will involve a completion of the Fontan circulation. Here, the inferior vena cava will be directed to the pulmonary artery either through an extracardiac conduit or a lateral tunnel as a total cavopulmonary connection. In this apical four-chamber view, we can visualize the extracardiac conduit lying immediately outside the atrial cavity. We can see the normal mobility of the tricuspid valve, the hypoplastic mitral valve, the hypoplastic left ventricle, and a good functional right ventricle. Most of the patients who are palliated through the stage 3 Fontan completion for hypoplastic left heart syndrome, it is customary to leave behind a small fenestration in the extracardiac conduit so that there will always be a small right-left shunt. This four-chamber apical view shows the extracardiac conduit, and there is a small fenestration from the conduit, and there is a continuous blood flow from the conduit into the right atrium. When we interrogate the spectral Doppler pattern of the flow across this fenestration from the conduit into the right atrium, we notice that there is a mean gradient of around 6 millimeters of mercury. This is the pressure gradient between the mean pressures in pulmonary artery to the mean pressures in the pulmonary vein. In contrary to the previous patient who had a very good right ventricular systolic function, patients who are having poor right ventricular systolic function will have more abundant fenestration flows. In this example, we can notice that there is a significant right ventricular systolic dysfunction. The tricuspid valve has been repaired with a ring annuloplasty, and the extracardiac conduit is visualized immediately outside the right atrium. In these patients with reduced right ventricular systolic contractility, we can notice that the Fontan fenestration flows will be abundant. We can also notice that in spite of the tricuspid valve repair that has been done with the annuloplasty, there is a mild tricuspid regurgitation. After a Fontan completion is done, if the patient is doing very well with a good right ventricular systolic contractility and the tricuspid regurgitation is very negligible, the inferior vena cava will not be grossly dilated. In this example, in the subsified view, we can notice that the IVC is very minimally distended. However, in poorly functioning Fontan with reduced right ventricular systolic contractility and significant tricuspid regurgitation, the inferior vena cava will be markedly dilated. To summarize, hypoplastic left heart syndrome is a very heterogeneous entity. There will be varying degrees of hypoplasia of the left-sided heart structures that include the mitral valve, the left ventricle, and the aortic valve and ascending aorta. We went through a series of examples of a wide range of hypoplastic left heart syndrome, and also we showed the various levels of palliation.